All righty. So here we go. Here's a disclaimer that we now put in every lecture. Here are our objectives for today. At the end of the presentation, my hope is you'll all understand that cardiovascular disease is a chronic inflammatory disease, that traditional risk factors are important and they're inflammatory triggers. And we're also going to talk about the role of sex hormones in cardiovascular disease. What are our goals when we talk about cardiovascular disease? Well, we want to prevent cardiovascular events in those at risk and in those with what we'll call subclinical cardiovascular disease, and that's typically called primary prevention. And we want to prevent secondary events in those who've had a prior event. Now, this is a patient of mine who presented to the emergency department in 2010 on Christmas Day after a large Christmas meal. And while he was being, triaged into the, heart room, he had ventricular fibrillation and sudden cardiac death. He was resuscitated, taken to the cath lab, and here is his right coronary artery with what you see train tracking here. As you could see the shadow along the outside, that's all thrombus in there. And after we put a stent in, he has a nice wide open with what's called TIMI 3 flow, brisk flow. Some of you may say, Doreen, why'd you put such a long stent in there? Well, the bypass surgeon, if he ever needed bypass, doesn't see this part. This is intramyocardial, and the surgeon actually only sees the distal right coronary artery, the ongoing right coronary artery, and the PDA, the posterior descending artery. So he still has an adequate bypass target. So let's start with what we know. As Noah said, it is still the #1 killer in both men and women, even though the incidence is going down. It is not a lipid storage disease. Years ago, it was thought that if you decrease lipids to like -0, you will decrease cardiovascular events. And what they found is no matter how low you decrease somebody's cholesterol, their LDL cholesterol, 50, 40, 30, it didn't decrease events. What they found was that it was a chronic inflammatory disease. And Peter Libby discovered this in the 90s. And what he noted was that inflammation is the key driver during all stages of the atherosclerotic process, from initiation through progression to ultimately end organ damage. Yes, risk factors matter, they're inflammatory triggers, and they impact cardiovascular risk. So how does cardiovascular disease happen? Well, the first step is actually glycocalyx degradation. The endothelial glycocalyx, which we'll talk about in a little bit, gets degraded. And what happens is that is what leads to endothelial dysfunction. Endothelial dysfunction leads to what we call leaky blood vessels. Leaky blood vessels lead to LPS translocation, right? Just like a leaky gut does. LPS-induced LDL oxidation occurs, you get oxidative stress, you get immune activation, and you get atherosclerotic plaque formation. Now, vascular inflammation occurs at the same time as lipid accumulation occurs. You get lipid oxidation, you get inflammatory cells, you get monocytes proliferating, they become macrophages, which are insatiable. They continue to uptake LDL, they become foam cells, and eventually they develop a fibrous cap. And really what you want is a thick fibrous cap. And if you think about one of those cordial cherries, if the dark chocolate on a cordial cherry is really thin and you put it between your forefinger and your thumb and just, tap it, it'll probably crack and all that liquid will come out. And that's what happens when you have a thin fibrous cap on a coronary lesion. It typically ruptures at the angles because it's not thick enough. As the fibrous cap thickens and becomes calcified, it becomes, quote unquote, more progressive. And of course, you've all heard about functioning LDL as its importance in reverse transport. But one thing we don't think a lot about is the fact that HDL transports antioxidant enzymes into the intima. which breaks down oxidized lipids, neutralizing all the pro-inflammatory effects. Now, inflammation mediates hypertension, and hypertension mediates inflammation. Activation of the renin-angiotensin-aldosterone system increases reactive oxygen species. You get increased expression of oxidized LDL receptors. You get increased adhesion molecules, chemotactic factors, and pro-inflammatory cytokines. Hyperglycemia and even prolonged hyperglycemia, not just diabetes, leads to increased pro-inflammatory cytokines and upregulation of pro-inflammatory pathways. And now we add obesity to this equation, and what you get is, of course, as you know, adipose tissue is an endocrine organ. It's pro-inflammatory. You get synthesis of pro-inflammatory cytokines, more inflammation, you get more atherogenesis. And this has not changed, even though Peter Libby published this in 2005. This is the reduction in vascular events that you get with aggressive lipid lowering. And here's your residual risk. And really, despite all the advances in lipid lowering, diabetes, hypertension, there still remains a significant residual risk. So I'm going to ask the question, are we chasing the wrong targets? And the answer, I'm going to tell you, is yes. And inflammation is one right target. I've already told you that, but to prove it to you, let's look at the Jupiter trial. It was a primary prevention trial, a large, long-term, double-blind, placebo-controlled trial, and they wanted to look at Crestor 20 milligrams a day, and they wanted to see that in apparently healthy people with normal LDLs and elevated hsCRP, whether it would decrease events. And the reason there are quotes in the apparently quote-unquote healthy people is because 41% of them had metabolic syndrome. And there was a large number of women in this study. And what they found was that there was a 44% decrease in cardiovascular events, despite no significant change in lipids. So the conclusion they came to was, regardless of your LDL, patients with elevated hsCRP will benefit from statin therapy with reduced cardiovascular event rates. Now, I'm not telling you to give statins to all of your patients. I'm just trying to show you that statins, which are immune modulators, will decrease C-reactive protein, decrease inflammation, and decrease events. And when we look at a secondary prevention trial, which these were essentially MI patients, and most of them had revascularization, and they were randomized to 3 doses of this IL-1B inhibitor every 3 months. And these patients were on optimum medical therapy. So they were on ACE inhibitors, they were on beta blockers, they were on optimum statin therapy, they were on aspirin, they were on an antiplatelet, agent like Plavix. And so what they found was that after 3.5 years, there was a modest but significant 40% relative risk reduction in inflammatory markers and a 15% relative risk reduction in MI, stroke, or cardiovascular deaths. These are modest reductions, but I want to point out to you what I found to be the most significant part of this was that the placebo group that had an LDL of approximately 80 on optimum medical therapy had a 25% 5-year event rate. That's significant. And they concluded that an immune modulator like the IL-1B inhibitor significantly decreased cardiovascular event rates, independent again of lipid lowering. The problem with this drug is that the infection rate was high, the death rate was high, and it was very, very expensive, so it never went any further. And so here are some key points that you can, if you just want to look at key points, it's a chronic inflammatory disease and decreasing inflammation in the absence of lipid lowering. So it's not about lipids, it's about inflammation will decrease cardiovascular event rates. Risk factors matter, are inflammatory triggers that, if not addressed, increase cardiovascular adverse outcomes. And decreasing the inflammatory burden will decrease vascular events. And so clinicians should continue to do what our traditional peers do, which is risk factor prevention and treatment. And we're going to add to this prevent and treat all nituses of inflammation. And here's where functional medicine and the Dutch test come in. Well, HPA Axis is one right target. And cortisol drives inflammation and cardiovascular disease. It leads to oxidative stress. You'll get endothelial glycocalyx and endothelial dysfunction in all blood vessels, not just in coronary blood vessels, in cerebrovascular vessels, in renal vessels. But we're going to start with what the HPA axis tells us about cortisol and cardiovascular disease, and then how do we measure this risk. I'm going to just point out 4 studies. There are tons of them. These are 4 firsts. So, and the full references for you are at the end. The Inner Heart study was really a case-controlled study. It was the largest study to assess long-term stress and coronary artery disease. This was based on questionnaires. This was not based on actually looking at salivary or urinary cortisol. There were 15,000 MI patients, and there were about 800 controls. And they wanted to determine really the strength of the association between cardiac risk factors and acute MI. And what they found was that the odds ratio of an MI, of having an MI, was more than doubled in individuals with chronic stress, in addition to conventional risk factors, when they compared them to stress-free individuals. And so they concluded that psychosocial stressors are significantly related to acute MI risk in all populations. And here is a graphic of what I just told you. Here's the odds ratio of having an MI. And as you add the number of risk factors, look how it jumps when you add obesity to diabetes, hypertension, and then look what happens when you add psychosocial factors. So stress matters, cortisol matters. And this was the first study, the Cardia study, linking cortisol patterns and coronary artery disease. They used salivary testing. This was 718 young participants when they were enrolled. So when they enrolled, you wouldn't expect them to have a lot of calcium. But it was a 15-year follow-up. And really what they wanted to see is if coronary artery calcium, a surrogate cardiovascular marker, was associated with average daily cortisol levels and the diurnal slope. And what they found was that a flat diurnal cortisol curve was associated with coronary artery calcium. And when they compared the group with the steepest slope here to the group with the flattest slope, the group with the flattest slope were 3 1/3 more likely to have coronary artery calcium. And they concluded that HPA axis dysfunction may indeed affect coronary artery disease risk. Now let's talk about mortality. The Whitehall study was the first study to document that daily salivary diurnal patterns are predictive of subsequent cardiovascular mortality. Over 4,000 men and women, their average age was 61, so these were middle-aged individuals, and the follow-up was about 6 years. And they wanted to determine or examine the association between cortisol patterns, cardiovascular and non-cardiovascular mortality. And what they found was a flattened cortisol curve was statistically significantly associated with increased cardiovascular mortality, but that wasn't all. An elevated PM cortisol was an independent predictor of subsequent cardiovascular mortality. There was no association with waking cortisol or CAR. So they concluded that a flattened curve and elevated PM cortisol levels are robust cardiovascular mortality predictors in middle-aged adults, men and women. Here's a urine study. This was the first urine study to document that 24-hour urinary-free cortisol levels predict cardiovascular mortality. This was 862 older individuals. Their mean age was 74. There was a Significant number of women enrolled. This study went on for 6 years, and they took the urine samples at baseline. And they divided the urinary free cortisol into 3 terciles: low urinary cortisol, moderate urinary cortisol, and high urinary cortisol. And they wanted to determine whether these 24-hour urinary free cortisol levels would predict all-cause and cardiovascular mortality. And what they found, it was a strong predictor of cardiovascular mortality. In fact, those in the highest tercile, whether they had no baseline cardiovascular disease or baseline cardiovascular disease, had an increased cardiovascular mortality. If they started out with no baseline cardiovascular disease, they had a 6 times increased risk of dying from cardiovascular disease. If they had baseline cardiovascular disease, they had a 9.2 times increased risk. So along with salivary cortisol, urinary free cortisol is a strong cardiovascular mortality predictor in persons with and without baseline cardiovascular disease. And what about inflammatory markers? I told you it's an inflammatory disease. So the MESAS study looked at cortisol patterns, cortisol curves over 3 days, and they asked 2 questions. Was there a relationship between diurnal cortisol curves and IL-6, IL-10, and TNF-alpha, and was there an association between total cortisol output measured by area under the curve and IL-6, IL-10, and TNF-alpha? And this was a sub-study of the large MESAS study. There was 869 adults. And what they found is in those individuals who had a higher IL-6, this was statistically significantly associated with a lower cortisol awakening response, a flatter slope, greater area under the curve, higher TNF-alpha with lower waking cortisol. Higher IL-10, nothing statistically significant. So HPA axis dysfunction basically may mediate associations between stress and inflammation. So here are some key points. Cortisol is an acute and chronic stress marker. Chronic stress is significantly associated with MI risk. Cortisol is a strong predictor of cardiovascular risk, events, and mortality. You can use salivary cortisol, you can use urinary cortisol. They'll both tell you a story. And so what does the literature tell us? It tells us that chronic stress and HPA axis dysfunction increase inflammation, cardiovascular disease risk, events, and mortality. Now, how do we measure this risk? Well, saliva is the gold standard for HPA axis testing. And before you choose a test, other than what's considered the gold standard, and we're going to talk about more about this next week. In this case, it's saliva testing. The test should be validated against the gold standard or studied and documented to improve clinical outcomes. And so you can use urine. This is a commercially available validated urine test that was published in peer-reviewed journal by Newman et al. Yes, this is the Dutch test, whereby they want to determine the utility of dried urine to measure cortisol and cortisol metabolites. And because liquid urine is the gold standard for urine, they looked at liquid urine and can the diurnal pattern be observed in urine. This was 68 people who did urine and saliva on the same day. And the light green is salivary cortisol, the dark green is urine. Now, I need to point out to you that this, which is saliva, is a cortisol awakening response. When you sense waking, not when you're awake, when you first sense waking, you do your swab. And then 30 minutes later, you do your second points, and that's the cortisol awakening response, a test of resiliency and responsiveness. This is the first point on the urine test, which is all the urine in your bladder from the night before and the early morning. The car is somewhere in here, but this second point, oh, let's see, how many hours later, is not a car. So if you're looking for a car, you need to do salivary testing, which we offer, and if you're not looking for a car, then I would start with the Dutch Complete, which has the urinary diurnal pattern and the cortisol metabolites, and they concluded, you all can read this, that it was a good surrogate for the salivary diurnal pattern. So yes, you can use this. So now let's look at some examples. And so this is urine. And the first thing you see is this is let me orient you. This is the lower end of the reference range. This is the upper end of the reference range. And what you see is this first point is really high. So this individual didn't sleep well, and really their brain had a hamster and a wheel in it, and the hamster was running all night long. And as you see, after this point should come down, right? Here it's a little flat, but here it's definitely flat. So you have increased coronary artery calcium, you have increased IL-6, and here you have increased cardiovascular mortality. Here from the Incianti study, you see a high 24-hour free urinary cortisol, increased cardiovascular mortality. When here you have saliva, you see this lowish first morning point. Elevated TNF-alpha, inflammation. You don't have to remember which pro-inflammatory cytokine is associated with what. Just remember, inflammation. Here you have a flattened curve. Inflammation, increased cardiovascular mortality. And then here again, IL-6, TNF-alpha, flattened curve, high nighttime cortisol associated with increased cardiovascular mortality. So when you order your Dutch test on your patients, will get lots of information about inflammation and cardiovascular risk from looking at a Dutch test. Now let's talk a little bit about blood sugar. Now, we don't measure blood sugar on the Dutch test, but I think this is really, really important. Two of the most undertreated cardiovascular risk factors are hypertension and insulin resistance. Underdiagnosed is obstructive sleep apnea. If we get these things right, we may be able to decrease risk. But the reason I bring up blood sugar, because I mentioned the endothelial glycocalyx. And what is it? It's a microscopically thin, negatively charged. I think of this thing as a gel-like, sugary coating that really blankets the endothelion's entire luminal side. And you see its makeup and its thickness will vary. So you really can't have endothelial dysfunction until you have endothelial glycocalyx degradation. It is really very important and provides the first line of defense. It acts as a barrier. It helps with filtration. It allows for active endothelial cell-to-cell communication, and it's responsible for vascular tone. But what's really important is that it is exquisitely sensitive to shear stress. In other words, its thickness. So if you have a uniform blood vessel, a straight tube, you will have a thicker endothelial glycocalyx. It'll be healthy. It should maximally protect the endothelium in optimum conditions. You'll get upregulation of eNOS, the enzyme responsible for converting arginine to nitric oxide, which is responsible not only for vasodilatation, but it has anti-inflammatory properties. In areas of low shear stress, bifurcations, curvatures, like the ascending aorta as it curves around to become the descending aorta, at the bifurcation of the descending aorta into the femoral vessels. There is non-laminar flow. Think of it as oscillatory, and it kind of is turbulent. This is where the endothelial glycocalyx is thin. It predisposes to atherosclerosis. And I don't know whether you've ever heard the term atherosclerosis occurs at branch points in blood vessels. This is why. The endothelial glycocalyx provides anti-inflammatory and antithrombotic effects by docking major proteins that are synthesized by the endothelial cells. Antithrombin 3 and its cofactors, the really potent antioxidant, superoxide dismutase. And here is what it's made up of. And just so you can get a picture in your mind of the endothelial glycocalyx. So here's your endothelial cell. This is looking down the barrel of the vessel, and here are these little hair-like projections, and there's your endothelial cells. And here's as if you've opened it up and are looking at it. Look at these, hair-like projections. Your endothelial cells are here. So it should make sense to you that you're not going to get endothelial cell damage until you get endothelial glycocalyx damage. And we'll talk about treatments for this a little bit this week, but more next week. Now, hyperglycemia, even when levels are increased for a short period of time, damage the endothelial glycocalyx. They decrease nitric oxide. And so if you have diabetes or if you have insulin resistance with long-term hyperglycemia, you get significant endothelial glycocalyx thinning, degradation, and vascular vulnerabilities. How can you tell? Do a urine analysis, cheap test. If you see albuminuria, this is one way of noting that you indeed have endothelial glycocalyx dysfunction. I'll show you a couple of more here in a little bit. You don't need a fancy test. And I'll also tell you that anybody who has risk factors, any risk factors, they are prone and indeed probably have endothelial glycocalyx dysfunction. Let me show you just a study, one study by Neudorf that was published in 2006. So this has been around for a while. These are healthy volunteers. There's their baseline glycocalyx volume, and there's their endothelial function by flow-mediated vasodilatation, something like an endopath. When they did a glucose infusion and raised blood sugar, look how the endothelius got thin and endothelial function decreased. So you had endothelial glycocalyx degradation, which indeed caused endothelial dysfunction. Now, mannitol was used as a control because mannitol isn't as easily absorbed as straight up glucose is, and so it doesn't raise blood sugar and insulin as much. But I want you to see here that when they added N-acetylcysteine to the glucose mixture, it mitigated the reactive oxygen species in induction of glycocalyx degradation. And you can see that better here. This is a component of the endothelial glycocalyx, and this is prothrombin fragments, and this is pure glucose. This is mannitol, and this is glucose added, N-acetylcysteine added to the glucose mixture. And you see the mitigation of the degradation of the endothelics. And so what they concluded was that hyperglycemia-induced reactive oxygen species upregulation, meaning increased reactive oxygen species, increased oxidative stress, increased inflammation, leads to endothelial glycocalyx degradation and shedding, decreased endothelial function with decreased nitric oxide, increased prothrombic potential, and if you give them N-acetylcysteine, and next week we're going to talk about arterisol, which has recently been patented for coronary calcification reversal, it will mitigate hyperglycemia-induced endothelial glycocalyx degradation. It's actually plaque reduction, not calcium reduction. I apologize for that. So again, optimum glucose regulation is key to endothelial glycocalyx and endothelial function. And by adding N-acetylcysteine, you will mitigate the damage that's done. But the real key here is be a bulldog about glucose regulation. It really is important. And so now let's talk about sex hormones, which is really an important target. As individuals age, men and women, it's associated with a chronic inflammatory state. You get increased pro-inflammatory cytokines, you get increased free radical production, and decreased redox potential, decreased anti-inflammatory potential to balance or mitigate those pro-inflammatory cytokines. Estrogen, progesterone, testosterone are immune modulators and anti-inflammatory hormones. They inhibit pro-inflammatory cytokines and stimulate anti-inflammatory cytokines. And as you can see here, there are receptors which are expressed in immune cells, endothelial cells, and vascular smooth muscle cells. So it should make sense to you that aging, which is associated with a decline in sex hormones, both influence immune competence and disease susceptibility. So let's start with males' testosterone and cardiovascular disease. We all know that testosterone gradually decreases 1% per year in men after the third decade. Testosterone is an independent determinant of endothelial function. Testosterone deficiency leads to endothelial dysfunction. You have decreased nitric oxide. You have increased expression of ADMA, which is asymmetric dimethyl arginine, which competitively, it's a competitive inhibitor of enos, which is responsible for converting arginine to nitric oxide. So you don't get nitric oxide. Now, what increases ADMA? You name it, it increases it. Anything that increases inflammation is going to increase ADMA. Hypertension, hyperlipidemia, tobacco use, you name it, it happens. It also, testosterone deficiency decreases what are called endothelial progenitor cells, which are involved in the endothelial repair process. It increases pro-inflammatory cytokines, and replacing testosterone decreases pro-inflammatory cytokines and increases anti-inflammatory cytokines. And this is a very nice article. The full reference is for you in the back, which I would recommend reading. And this goes for both men and women. Aging in conjunction with testosterone deficiency increases all the bad stuff, which leads to endothelial glycocalyx dysfunction, endothelial dysfunction, large artery stiffening, which leads to increased blood pressure, increased afterload, left ventricular hypertrophy, diastolic dysfunction, endothelial injury, and increased risk for cardiovascular disease. Now let's look at a study this is out of Kerry Moreau's lab, and what they did, they wanted to determine if middle-aged or older men with low total testosterone would have greater age-associated endothelial dysfunction related to inflammation and oxidative stress. They looked for guys with different testosterone levels. 58 healthy men, 20 younger, 20 middle-aged, and 20 middle-aged with lower testosterone. And here are your testosterone levels. And so let's come over here and look at what happened. They used vitamin C as an antioxidant to see if it mitigated endothelial dysfunction. Here's your young guys, which are in essence your controls. They infused saline, there's their baseline, and when they infused vitamin C, 100 cc's, there was really no change. This is all the men together, all the middle-aged and older men, not separated based on their testosterone levels. And what they found, they had lower baseline endothelial function. And when they gave them vitamin C and compared it to their baseline, it was statistically significantly better. But it was still statistically significantly worse than the young guys who really had no change. And then when they divided the group based on their testosterone levels, what they found is that in the middle-aged or older men with higher testosterone, there was a statistically significant difference in endothelial function when compared to the younger guys, here and here, that was no longer statistically significant when they infused vitamin C. So it mitigated some of the oxidative stress and improved their endothelial function. Now, when they looked at the middle-aged and older guys with lower testosterone levels, what they found was that at baseline, they were statistically significantly lower than their middle-aged peers with higher testosterone, and certainly statistically significantly lower than the young guys. When they gave them vitamin C, they were no longer statistically significantly different from their peers. They significantly improved over their own baseline, but were statistically significantly different than the young guys. And so they summarized that by saying middle-aged older men with lower total testosterone levels may have accelerated vascular aging as a result of age-associated endothelial dysfunction compared with their matched peers. And they felt it was due to increased inflammation and oxidative stress, which was, as I showed you, mitigated by vitamin C. So they concluded that physiologic total testosterone levels, which are greater than 500, but less than 1,000 with a goal of greater than 500 to 800, may attenuate the age-related decline in endothelial function. This is independent of symptoms and independent of traditional risk factors. And this is by decreasing inflammation and oxidative stress. So you can make an argument in asymptomatic guys who have low testosterone levels. Typically, they're not going to be asymptomatic. At a testosterone of a mean of 269, you can make an argument for cardiovascular protection. So testosterone improves endothelial function, and TD leads to endothelial dysfunction, inflammation, oxidative stress. So why, I ask you, is there a black box warning on all the testosterone prescriptions that read there's a possible increase in cardiovascular disease? Well, 4 studies, accuracy, validity, and credibility, today are still questioned by experts. They want them removed from the literature. The FDA questioned it, even though they found no reason to put a black box warning on all testosterone prescriptions, actually mandated the warning. And here are the 4 studies. The TOM trial by Basaria wasn't a cardiovascular study. They wanted to see if testosterone gel increased strength and physical function in elderly, frail men. And it did do that. But they stopped the study early because of quote unquote cardiovascular events. And these events were palpitations, PVCs, nonspecific EKG changes, and pedal edema. So they really weren't cardiovascular events. However, there were 4 events that were significant that occurred in men whose testosterone levels were greater than 1,000 and were given then higher than recommended doses. So the moral of the story is keep them within the recommended ranges. Vigan did a retrospective study looking at men who underwent coronary angiography and received testosterone prescriptions. Their initial results said 3 years after angiography that T prescriptions were associated with increased cardiovascular events. However, the data was flawed. 10% of the participants were women, and when they did a reanalysis of the study, what they found was that those who received testosterone had a 10.1% absolute event rate, while those who did not had a 21.1% event rate. And then the Finkel study compared post-prescription MI rates to pre-prescription MI rates, which are really studying different things. There was no validation of actual events. They, aside from no control group, they never measured testosterone levels. They don't look at risk factors of these individuals. And really, when you look at the data with a fine-tooth comb, what is there is that T-related events were lower than what we would expect in the general population. And then Sue looked at, published a meta-analysis, and 2 of the studies composed 35% of the events. One was this Basaria study, and the other one is just an unusual study. It was the Copenhagen study where they gave high-dose oral methyl testosterone, which resulted in supraphysiologic levels to men with cirrhosis. I'm not sure why somebody would do that. Levels went up as high as 20,000. And the most common cardiovascular event was esophageal varices and varicose bleeding. I'm not really sure that's a cardiovascular event. When those 2 studies were removed, there was no statistically significant difference in event rates between T-treated men and non. So these 4 studies are what prompted the black box warning. Here are a bunch of studies for you that documented no increase in CIMT or coronary artery calcium, documented decreased mortality, MI, and stroke reduction when you gave testosterone. So there's lots of data out there that support the use of testosterone in men and not to worry about cardiovascular disease. So should there be a black box warning? Probably not. The Traverse trial is ongoing now, and my dear friend Mohit Khera is a principal investigator, and all he could tell me is that this study, things are looking good. And what that means to me, they haven't stopped the study early, and it is looking at testosterone and cardiovascular risk. And I look forward to the publications so we can clear all this mess up. And so here are some key points in men. Serum is the gold standard, and we'll talk about that next week. But regardless of the dose or the delivery method, you want to keep serum total testosterone levels greater than 500 to less than 1,000. And that should be your goal. That will optimally improve clinical outcomes. Because in one of the studies here, what they found was that in men who received testosterone, but had lower testosterone levels than what would consider optimal, didn't have as great a mortality reduction or MI reduction as those who had normal levels. So the key takeaway is maintain testosterone in the therapeutic range. And you want to make sure that no guy has a testosterone level that's less than 200. You need a level greater than 200 with intact aromatization to prevent marked and significant bone loss. And estradiol is very important in men for bones, for sexual function, as well as for cognition. And remember, you're going to use an LCM-SMS assay when you're going to measure E2 levels, because at the lower end of the reference range, any immunoassay is not as reliable. And remember that serum testosterone levels are generally higher with gels than creams, and you may need up to 2 times the cream dose to achieve similar total testosterone levels and clinical outcomes. And so what about women? Estradiol is similar to testosterone. It increases endothelial nitric oxide production. It decreases inflammatory peptides. It has direct antioxidant effects. It increases mitochondrial antioxidant defenses. And what has been found is that if you don't have enough estrogen, estrogen receptors will decrease and estrogen receptor signaling will decrease. ER alpha is the key determinant, and E2 modulates endothelial cell expression, which impacts receptor signaling, sensitivity, and function. Let me show you what I mean. This was a study done, again, at Kerry Moreau's lab, which looked at, this is a small study, vascular endothelial ER alpha expression, and wanted to see whether it was influenced by E2 status and whether it was related to endothelial function. They did immunofluorescence staining of peripheral venous endothelial cells, and they used brachial artery flow mediated vasodilatation, something like the Endopat. And so remember, these levels were not LCM-SMS levels, but premenopausal in the early follicular phase was similar to the postmenopausal phase, and in the late follicular phase, they were higher. And when you look at the immunofluorescence staining, you see the fluorescence staining is about 30 and 33% less than in the late follicular phase. And what they found was that ER alpha expression was positively associated with E2 levels, ENOX expression, and activation. Now let's look at actually endothelial function. And what they found is that as ER alpha density increased, i.e. as serum estradiol levels went up and ER alpha density increased, there was improved endothelial function. So they concluded that serum E2 may regulate ER alpha expression, which influenced endothelial function by modulating ENOS. So We talked about postmenopausal women and premenopausal women, but we have to ask the question, do the hormone changes that occur during the menopause transition, which a lot of clinicians don't pay close attention to, accelerate vascular aging and contribute to endothelial dysfunction? So this is the modified straw criteria, and here's where they define the early menopause transition, and this is the late menopause transition, which is really amenorrhea for more than 2 months. And so again, this is out of Kerry Moreau's lab, and they wanted to determine whether the menopause transition affected endothelial function as measured by brachial artery flow mediated vasodilatation. This was a study that included 132 healthy women. None of them were on hormone. And here are the definitions according to the modified straw criteria. Early was greater than 2 cycles with cycle lengths greater than 7 days. Late, amenorrhea greater than 2 months but less than 12. And there's your menopause. And you all remember that menopause is defined by no cycle for 12 months. And what they found is the menopause transition was associated with endothelial dysfunction independent of risk factors. So here's your premenopausal women, early perimenopause, late perimenopause, early postmenopause, late postmenopause were all statistically significantly had less endothelial function or more endothelial dysfunction than your premenopausal women. But this statistical significance was not as robust as the others, and they thought that these women may have enough hormone available to provide some endothelial protection. But once you got to the late perimenopausal stage, and again, this is not using LCMS-MS, what they found was you had accelerated vascular aging. But what was very interesting is that there was no statistically significant difference in endothelial function between late perimenopause and the postmenopause period. So here is your time frame to pay attention to. This is when you get accelerated vascular aging. So the menopause transition is associated with a significant decline in endothelial function. So the menopause transition is a critical period during which CVD risk accelerates. And so the answer to our question is yes, but what about menopause, estradiol, and cardiovascular disease? Lots and lots of studies, which I have for you in the back. We're going to focus on 2. The ELITE trial was a study done using oral estradiol, 1 milligram, and vaginal progesterone gel, 45 milligram days 1 through 10. They never got the message that you need to use it for at least 12 days. But they had no endometrial complications. And so what they found was that, so let me come up here for you. And there were 2 study groups. One was less than 6 years, was defined as the early group, and then the late postmenopausal group were menopausal for greater than 10 years. Most of these women had some degree of subclinical atherosclerosis. They had abnormal CIMTs, which put them in that category. And what they found when they looked at the whole group together is that oral estradiol in the early postmenopausal group slowed CIMT progression compared to placebo, but it was only present at 5 years. And that shouldn't surprise you, as coronary disease is a slowly progressive disease. And that may be why when you look at the KEEPS trial, there was no statistically significant difference in CIMT between the treatment arm and the placebo arm, and that was only a 3-year trial. But when they did sub-study analysis looking at estradiol levels, here's where the groups kind of diverged. In the early postmenopausal group, the higher the treatment serum E2 level, the slower CIMT progression. And their E2 levels had a mean of 48. Late postmenopausal women, the higher the serum E2 levels, CIMT progression rate was increased, and their mean was 40. So the moral of the story is if you use serum, you want to keep them probably between 20 and 30 to 35, and we'll talk about the urine equivalents here in a second, the Dutch urine equivalents. And in a earlier postmenopausal women, you can take them, to 40 to, somewhere between 40 and 60, and you'll get CIMT slowing. Now let's look at the FINISH trial, which why I pulled out the FINISH trial was because they used not only oral estradiol, but they used patches, which we use. They used gels. They didn't use creams. Unfortunately, they used progestins. But even despite using progestins, in all estradiol users, coronary artery disease-related death, mortality, was reduced by up to 54% in a time-dependent manner, meaning the longer a woman was prescribed and used estradiol-based hormone therapy, the greater the risk reduction. And this is important because the guidelines say something different. All risk reductions were comparable in women initiating hormone therapy below the age of 60 and in women initiating therapy greater than or equal to 60 years old. And so here's a summary. Estradiol's cardiovascular mortality reduction is positively related to E2 exposure. Patches, gels, orals have been associated with decreased cardiovascular mortality. Treat women as early as possible. It's okay to initiate therapy later, and treatment may be continued for greater than 10 years, so long as you initially risk stratify the individual and you continue with ongoing risk stratification. Don't forget women with a uterus. Get oral micronized progesterone or vaginal progesterone. It doesn't increase cardiovascular risk. It may provide some cardiovascular benefits while protecting the endometrium and improving bone mineral density. And I'll throw this in here. When you add testosterone therapy to transdermal estradiol and oral micronized progesterone and vaginal progesterone, you will get an improvement in endothelial function and bone mineral density that is greater than E2 and progesterone alone. And then just summarizing what we just talked about with the ELITE trial, recently menopausal women, depending on their cardiovascular risk, may require higher serum levels. And remember, we validated the Dutch test is validated, and so that 40 to 60 is a dry urine equivalent of about 1.8 to 2. And older postmenopausal women, 20 to less than 40, which is equivalent to 0.7 to approximately 1.3 to 5 on the Dutch test. And this is regardless of cardiovascular risk. Older postmenopausal women do not need estradiol levels of 60, 80, 100. They don't need it. They're not going to have babies. They need to protect their heart and their bones. The data on replacing estradiol and cognition is mixed. And again, time since menopause and age greater than 60 should definitely cause pause, but it shouldn't prevent you from initiating hormone therapy or continuing it. Ongoing risk stratification and follow-up testing is a must in all women as well as men. So when you counsel patients, remind them that estradiol is not indicated to prevent adverse cardiovascular outcomes in either men or women. However, the data suggests that it'll improve cardiovascular outcomes, and the earlier you initiate therapy, the greater the benefits. So why isn't E2 indicated to prevent adverse outcomes? Well, the guidelines got it wrong. They base their recommendations on synthetic hormones. This is the position statement out of from 2017 from the North American Menopause Society. For women who initiate menopause hormone therapy more than 10 to 20 years from menopause onset or at age 60 or older, the benefit-risk ratio appears less favorable because of the greater absolute risk of coronary artery disease, stroke, venous thromboembolism, and dementia. This statement is based on the WHI data, which aren't relevant. Nobody should be using oral estrogens. I don't care even if it's orally too, they upregulate inflammatory markers as it gets to the liver. In fact, the guidelines do remind us that oral micronized progesterone and vaginal micronized progesterone, not a progestin, is the treatment of choice. They also say that TDE2 may be preferred, especially in certain high-risk populations, which is what we're talking about. But I will tell you that prior to initiating hormone therapy in all women, especially older women, re-stratify them. Look at their endometrial health. Think about it. Their breast health, their bone health, their cardiovascular disease risk factors, as well as cognition. You want to do ongoing surveillance. And this is not one size fits all, individualized care. And here's just some practice points. Initiate menopause as close, initiate hormone therapy as close to menopause, continue as long as appropriate with ongoing risk stratification, surveillance, and follow-up testing. This is the stuff I've already told you. And for those women who can't tolerate a patch, which is what I would start with, which we'll talk about next week, TDE2 gel products are reasonable options. However, they're not FDA approved for bone mineral density. And the reason is when they compared gel products, they compared it to what the standard was, which was a patch. And what they found is you need higher doses and higher serum levels to get bone mineral density equivalency to a patch. And that was the reason it wasn't approved. Compounded products probably work. I use them at times, but they have no outcome data. So you just need to document in the medical record why you're using a compounded product instead of a FDA-approved product. And remember to test, don't guess, include metabolomics, which are necessary for a successful hormone practice. I can't practice without it. It tells me about tissue exposure. It gives me hints as to upregulation of inflammation. It adds a lot to my practice. And so final thoughts, cardiovascular disease is a chronic inflammatory disease. It's not a lipid storage disease. It is not enough to treat and optimize all traditional risk factors. To optimally mitigate cardiovascular risk, we should address all inflammatory triggers, the HPA axis and the autonomic nervous system. I didn't talk about the autonomic nervous system today. The gut and TMAO. TMAO is an independent prognostic indicator in individuals with and without cardiovascular disease. How does one get high levels of TMAO? They eat a high phosphatidylcholine or choline and carnitine diet, and they have dysbiosis, which makes TMA, and TMA gets sent to the liver, and it becomes TMAO. And remember that poor detoxification increases inflammation, and hormone matters. They're inflammatory modulators. Hormone deficiencies are associated with increased cardiovascular risk and adverse cardiovascular outcomes. Test, don't guess, and let's give you a little preview to next week. We're going to use case studies, and we're going to talk about an approach to the patient. Key things you should look for in the history. What laboratory tests you should be doing. Then I'll highlight some treatments, and my hope is I will give you an algorithm for cardiovascular risk stratification that will be useful to you. And I can't leave today without talking a little bit about laboratory testing, depending on delivery. And green is yes, which is go. Red is no, and yellow is maybe, think. And this will be very, very helpful for you regarding when to optimize, when to optimally use the Dutch test, when the Dutch test may be helpful, and when not to use the Dutch test. And with that, I will show my little puppies, which always make me smile, and I'll open this up to questions. And let me remind you about the new provider 50% off. And I just need to ask you guys, if you aren't Dutch providers, why not? It is a great test. It is validated. It has serum equivalence, and it's evidence-based. In addition to it giving you a ton of information. So the link is in that little chat thing below, not below here, but in the chat box. And I will be more than happy to answer any questions, and just know there are additional references for you of all that I've talked about. And Noah, you're on.
Thank you, Dr. Saltiel. We do have a few good questions from the audience already in the chat. I won't be able to get to all of them with the time we have left, but let's dive into what we can. And remember, Dr. Saltiel is a doctor, but she may not be your doctor. The contents of this webinar are intended to be for educational and informational purposes only. Please consult with your primary care physician before starting any new treatment plans. So Dr. Saltiel, the first question is, and we're gonna go really easy on you here and start back where you ended. For those in perimenopause, it is very difficult to figure out when to do the Dutch test. Any tips on when to do the Dutch test in perimenopause?
Well, if women aren't having regular cycles and they don't know when they ovulate, because a lot of women know when they ovulate, you can get an ovulation kit, which Noah can talk about. There are a number of ways to determine when a woman ovulates, whether it be body temperature going up by a certain number of degrees. But if all of those things fail, or you choose not to do those, pick a day and just do the test.
All right, perfect. Do you use Arterisol? And if so, when do you use it for cardiovascular disease patients?
Yes, and Arterisol, we're going to talk about that next week. But yes, I use Arterisol in any individual I think has endothelial dysfunction, which means if they have cortisol dysregulation, they have endothelial dysfunction. And endothelial glycocalyx dysfunction, because remember, you got to get through that endothelial glycocalyx. Anybody with cardiovascular risk factors, anybody with any degree of insulin resistance. Now, even though it's not approved for the gut, right? The gut has endothelial cells. And so if individuals have inflammatory bowel disease, if they have significant dysbiosis, irritable bowel, I'll give it to them. So anybody who I think has endothelial dysfunction and endothelial glycocalyx dysfunction, if they have elevated triglycerides, if they have elevated lipids, you know, it's really, who wouldn't I give it to?
Are there any other supplements that you believe would help endothelial glycocalyx?
That's the only one that's been approved for plaque reduction. There are other ones out there on the market, but they have not been approved for this purpose.
Sticking with my new favorite word, endothelial glycocalyx, how high of glucose does the endothelial glycocalyx damage start at?
I would, just so you know, I would say it's probably at 70, 80. And why do I say that? I didn't talk about autonomic dysfunction, but as blood sugar goes up, heart rate recovery time, which is a marker of sudden cardiac death, decreases. And when you get a decreased heart rate recovery time in individuals with blood sugars that would be considered normal, especially if their heart rate is greater than 80, their baseline heart rate is greater than 80, they're going to have significant endothelial glycocalyx dysfunction.
Could endothelial glycocalyx degradation be implicated in Raynaud's disease?
Yes.
If a female starts testosterone, will they be on testosterone like men forever?
Yes.
Throwing all the easy ones. These are just softball for you, right?
Yeah.
Does lowering cholesterol with statins inherently lower testosterone?
No.
So those two are not together.
No.
Do you have any suggestions for men with a history of prostate cancer who are given meds to decrease testosterone?
Well, if they're actively being treated for prostate cancer, the answer is there's nothing to do, right? When they get further out from prostate cancer, consult with your urologist. Most of them know that testosterone does not cause prostate cancer. That's been well proven. So you need clearance from the urologist, and then at some point, you could probably initiate testosterone therapy. That's not with metastatic prostate cancer. I'm talking about people who are disease-free for anywhere from 1 to 3 years, depending on the urologist.
Would you still prescribe estradiol to a postmenopausal woman with some cardiovascular risks, even if they had a history of estrogen-positive breast cancer?
Yes, it depends on how far out they are from breast cancer, number one, and the answer is yes. Estrogen decreases breast cancer. Estradiol decreases breast cancer. So there's no reason not to. And I risk stratify everybody.
What are some of the
Oh,
tools that you use
let
for
me spell.
risk
Hey,
stratification? Yeah,
hey, no, let me spell arterosyl. Arterosil. That's how you spell arterosyl. There you go.
perfect. Thank you.
And what are the tools I use? Very interesting. I'm going to talk a little bit about this next week, but you really can't use any of those calculators because they don't take any of the things we just talked about today into account. But if you start there, and I think somebody has increased cardiovascular risk, I either do a CIMT and or, depending on the person, a coronary artery calcium scan, which is typically where I go.
Would testosterone be recommended for someone with intermittent AFib?
Well, its effects on the conduction system have not been well studied. So if somebody had, you got to ask why they have intermittent AFib. Is it they have hypertension that's not treated well? Is it ischemic AFib? So you got to really find the etiology of the atrial fibrillation. And then you do the same thing as you would do with any guy, which is you order the litany of tests, which we're going to talk about next week. You evaluate their symptoms, and then we decide whether they're a candidate for testosterone.
I'm going to send you down a rabbit hole with this one. When someone is on the birth control pill, is it accurate to check their hormonal status with the Dutch test?
Oh, you're going to get all these bizarre readings. And so my answer would be no, but the bigger question is, why are they on oral birth control pills? That should be the question. Nobody should be on an oral contraceptive, partially because it is a progestin. And progestins increase breast cancer. Progestins increase cardiovascular risk. So what you want to do is get them on a I would say a IUD that's non-hormonal, because even though they say it doesn't get into the circulation when you use a Mirena, it does, and those are not bioidentical hormones either. So my ideal contraceptive is a non-hormonal IUD.
And if a patient is looking for a baseline, how long should they be off birth control to be able to look at that in any testing?
Well, everybody's different, right? And I've had women who, after 3 months, their Dutch test looks fabulous. I've had women after 6 months, and after 3 months, their Dutch test looks like, what is, you're still on birth control pills? You didn't stop them? No, I stopped them. Some people you have to wait 6 months. So it's going to be a trial and error. There's no one size fits all.
Do you believe there's a limit to how much oral progesterone to use at night to help with sleep?
Well, it depends on their pathway predominance, right? So if you go down heavily during that alpha pathway, if you predominantly go down the alpha pathway and their alpha metabolites are already high, giving them more oral progesterone is not going to help you. And there is some data in vitro studies that going down that alpha pathway may increase the risk of breast cancer when you use an oral, even OMP. But in all the studies on oral progesterone, it did not increase breast cancer. So those were in vitro studies done by John Weeb. So it really is dependent on your metabolomics. That's my favorite word, Noah.
Metabolomics, I know.
Yeah.
It's my second favorite word after my new favorite word today. Is there any way to detox from progestin that has been taken from an estrogen dominant patient with fibroids?
Yeah, I would do a liver detox. I would do a 30-day liver detox. You can use Metagenics, which is very gentle. And then I put them on a detoxifying diet that they would eat along with that, eating lots of detoxifying foods.
What are some of the foods in that detoxifying diet?
Oh, cruciferous vegetables, beets. And when I talk about cruciferous vegetables, I'm talking about broccoli, cauliflower, Brussels sprouts, onions and garlic. If you can eat those are all detoxifying vegetables. And fruits, you want to eat berries, and more berries. The more colorful your diet is, the more detoxifying it is.
Eat the rainbow, and we're not talking about Skittles, right?
Yes. Oh,
Can you can you possibly discuss the inflammatory risk of low estrogen levels, specifically in premenopausal women?
Oh, yeah, women typically shouldn't have low unless they're, fluctuating up and down, or they're an athlete and their HPG axis has been turned off. And stress is the most common cause of anovulation and HPG axis down regulation. Yeah, their risk, the risk is the risk. And it depends on how long their estrogens are low for. So test, evaluate, and in a young person, you're not going to give them hormones, just like in a young guy. That's not going to be your first go-to. You are going to address all the underlying etiologies, all the stressors. Are they toxic? You're going to look at heavy metals. You're going to look at all those things before you go anywhere near hormones. And you got to figure out if it's a primary hormonal abnormality or a secondary hormonal abnormality. And most young women who have reached puberty and had a cycle, and they continue to have cycles, and all of a sudden they stop, is not going to be a primary hormonal abnormality. It's typically secondary.
Do you have any recommendations to improve detoxification when someone has the MTHFR gene?
Yeah, it depends on if you're a double SNP or a single SNP. And you really want to make sure your B vitamins and folate and everything in that methylfolate pathway is optimized.
In patients with menstrual migraine, is there any evidence for using bioidentical hormone therapy instead of OCPs?
Yes, there is. I don't know that data offhand, but that would be an interesting blog topic. Just like perimenopausal or just luteal phase depression, women who get depression based on their cycles, a lot of times it may not be the absolute value, it may be the up and down patterns, and it may be the relative hormone levels. And so again, that's where you would do a cycle map. Is going to be really, really important, because you just don't want to give hormones. You want to see when it's happening and why. And you also want to look at their HPA axis. Nothing is just one thing. It's all interrelated.
That's why the patterns are so important on the Dutch test, right?
Yep.
Little plug there. Can you explain why someone would have very low E2 but maybe have high E3 when they're looking at their Dutch test?
Well, I'd have to see the Dutch test. And remember, E3 is a metabolite. It's not a primary hormone. It's essentially a metabolite. So I would have to see what their metabolomics look like and how they're metabolizing 16-hydroxy to E3. Even though it visually it may look like a hormone, it is actually a estrogen metabolite. And why is their E2 low? Are they inflamed and their inflammatory pathways are upregulated and all of their metabolites are, higher than you would expect from a low E2 or a low E1? And remember, what we're looking at on the Dutch test is E1 to 16-hydroxy, 4-hydroxy, and 2-hydroxy. And remember, E2 does the same thing. It's a metabolite, but we don't show the E2 metabolites. And so remember, E3 is coming, from primarily E1, but there is some contribution from E2.
Someone asked a question that may be on one of the slides that you might want to pull back up. When progesterone is taken vaginally, how do you measure improvements?
Vaginal progesterone is the only hormone, the only progesterone that can be measured in serum. Remember, if you use the Dutch test, it's going to underestimate systemic exposure. Because the vaginal mucosa does not have 5-alpha and beta reductase enzymes. So you're not going to see progesterone going to its 5-alpha and beta metabolite, which is what we look at on the Dutch test. But you can measure serum levels. And you can look at serum to see what your level is. And in premenopausal women, you want to get into the lower end of you want to get into the luteal range, and depending on whether they have, and this is really complicated, whether they have depression, you're going to want to be either super high or you don't want to be too high. It's very, very complicated, premenopausal depression and postpartum depression. But if we're looking at postmenopausal women, you want to keep them towards that lower end of the luteal range. And this is plausibility argument I'm making for bone health. There's no research on vaginal progesterone looking at bone health. And what we know that in premenopausal women, they need luteal levels of progesterone for optimum bone production. So what I do with my women is I get them to that lower end of the luteal range.
Will you throw the BHRT matrix back up on the screen for me?
Would I?
We have a couple people asking questions about that specifically. So
you don't want to see my puppies? All right.
yes, those two. All right, we'll just leave that there because there have been a couple questions about that. So if you had questions about that, we'll leave it there for a little bit of time for you to read through that. You can see again the green check marks are when to use Dutch, red check mark will be no, and then kind of give you some different options below there. Dr. Saltiel, would you recommend doing a Dutch test on someone who is actively exercising the day that they're doing the test? And if so, their cortisol higher being during that day, is that normal for the situation, or what would you be looking at?
Well, I like to take people when they're in their normal state, right? What are their normal activities and what they're doing? Now, I don't recommend they do vigorous exercise when they're doing their Dutch test, because I'm not going to get a good reflection of their basal cortisol levels. What I'm going to get is exercise cortisol levels. And then how do I interpret that? I'd ask the question, other than in an exercise state. So I would recommend that the day of their Dutch test, they can certainly walk, but I wouldn't be brisk walking where they get their heart rate up and all of that. I would just kind of do strolling. So the answer is no, I try and have them not do vigorous activity.
And this will be our last question. Is vaginal progesterone safer than oral progesterone or a Mirena, and which is better to use for HRT?
It depends on the patient. Well, vaginal progesterone is not a birth control. So you have to remember, bioidentical hormones have never been studied in the birth control setting. And why is that? If you randomize two groups to 300 milligrams of oral progesterone or, I don't know, 200 milligrams of vaginal progesterone, and neither group of women want to get pregnant, and one group of women get pregnant, what happens? Yeah. So that's why it's never been studied as birth control. And so it depends on the patient. Typically in women who are having sleep difficulties, my first will be oral progesterone. But I do a Dutch test before I start. And you'll say to me, why in a postmenopausal woman would you do a Dutch test first? Well, even though their levels may be low, I look at trends and I want to see trends in pathway predominance. And then I'll give them 200 milligrams of oral micronized progesterone. And then I will retest in, say, 3 months or after 3 months of treatment. I use vaginal progesterone primarily in my reproductive women who are trying to get pregnant. If women have no sleep issues and they're sleeping just great, I give them the option, vaginal progesterone, oral progesterone. But the goal is endometrial protection. 200 milligrams is the only dose that's been studied in a randomized controlled trial. So I start with 200 milligrams. If you apply it directly to the vaginal mucosa, you are bypassing first pass metabolism. And in essence, you're bathing the endometrium with progesterone, so you know you're getting protection. But a lot of women don't like to use vaginal hormones. They just don't.
Well, thank you so much for all of your thoughts and sticking around for the additional questions. For everyone joining us, thank you for joining today. Please be sure to register for next week's follow-up conversation where Dr. Saltiel will be going further into detail on some of the topics that we've been going over today. If you have any additional questions about today's content or general questions about the Dutch test, please email our customer support team at info@dutchtest.com or call us at 503-687-2050 and we will get you in touch with the right people. Again, thank you so much for joining us today, and thank you to Dr. Saltiel. We look forward to seeing you next week.